Okay, hi everyone. Thank you all for joining. This is a webinar from the Global Observatory of Long-Term Care. Specifically, this is a webinar organized by the Global Perinatal Mental Health Interest Group. Adeline Comatera is the director of the observatory, and my name is Naz, and I work as a research coordinator at the GOLTC, and we'll be doing a quick introduction for the observatory today. So, what is the Global Observatory of Long-Term Care? The GOLTC is a platform for cross-national learning. It's designed to improve and strengthen care systems globally. Our goal is to identify shared challenges and showcase how different countries and communities are addressing them. This is an open space for anyone interested in long-term care, including policymakers, industry members, advocates, care professionals, and academics to share knowledge and foster collaboration. And the way that we make that happen is the GOLTC thrives on the willingness of its members to share knowledge and experiences. We share publications, build country profiles, and host blogs and guides on key topics and methods. And at the heart of the GOLTC are our interest groups. So these groups organize webinars, share resources, and collaborate on issues that matter most to them. And so we have a large variety of interest groups that all members are encouraged to join, steer, or consider making their own. And this is a space for learning, connecting, and driving change together. So as we talk about interest groups, I just want to quickly introduce some of the upcoming interest group webinars that we have, and this will also show the large variety of interest groups that we have. So on the 13th of May, we have the Continents in Care Long-Term Care Interest Group webinar. On the 19th of May, we have a webinar from the Workforce Capacity and Capability and also the Technology and Long-Term Care Interest Group. I believe on the 9th of June, it is the Migration, Mobility, and Care Workers and Social Care Reform in England Interest Group webinar. And on the 23rd of June, there is a webinar from the Pain and Care Homes Interest Group. And on the 7th of July, there is a interest group webinar from the Quasi-Experimental Methods Group. And this brings us to today, where we have a webinar from the Global Perinatal Mental Health Interest Group. And this is going to be a three-part series over the year. So this is part one, where we look at the practical cost calculator demonstration. And then following ones will be on the 29th of June and the 28th of September. I'll put some links in the chat after this so that you can essentially follow along. And when we get it posted on the website, you can register for it. So I'll hand it over to Annette now so that they can start their process.
Okay. Yeah, so my name is Annette Bauer. I'm associate professor at the LSE. I'm also the GEM lead, which is this kind of like new project that we have been working on over the last decade or two, almost 2 decades actually. But it's not just myself, but it's like a whole group of people I'm presenting today, just because I'm the kind of like economist behind it. But there are other people who can talk about different aspects, and I really encourage you to kind of like come in as and when you want to. And everyone else is really encouraged to kind of like ask questions. So we're using this kind of like Global Observatory for Long-Term Care platform as a really great opportunity to just kind of like organize webinars and organize additional activities. So it's great to have that for us. And obviously you might be interested in some of the topics that Naz mentioned, and feel free to kind of like sign up to the network, which then automatically links you to the GEM project as well, which is really great. And most of you have already done that. Let me just share. So yeah, as Naz mentioned, so we just organized this kind of like webinar series. And this is basically today just kind of like introducing the kind of like cost calculator tool that we developed with, in particular, colleagues in Thailand. And then we have another kind of like presentation on the 29th, where we are getting kind of the country experience around using economic evidence in perinatal mental health. So using that tool, but also like using other types of economic evidence, just really kind of like reflecting on the need for economic evidence in this area and what type of economic evidence we need to inform policy decision making in particular, with a focus on really kind of like, scaling and changing things in that field. And then there's another kind of like webinar towards the end of September, where we want to kind of discuss with you if you're interested in kind of like staying involved in this topic, like, just explore more how we might be as a kind of like network, potentially kind of like seek funding or like, get more kind of like people involved in kind of like thinking about economic evidence and what we're actually trying to achieve. And this is like all up to us. So it's really like there's no predefined agenda as such. So it's really more like a kind of like thing that is merging over time. Um, so yeah, so first of all, I should probably mention the work we have been kind of like doing over the time and how it all kind of like started. So some of you might know that we started doing work in 2014 in the UK. And so that was the kind of like initial work on the cost impact of perinatal mental health problems and had quite a big kind of like impact initially in the UK in terms of like leading to investments into specialist perinatal mental health service, but then also really had kind of like global knock-on effects. And we did actually do initial, like additional kind of like follow-on work funded often by NGOs like the Maternal Mental Health Alliance, but also like UK governments, NHS England, and also like the Royal Foundation. And then the kind of like core development, I guess, started in terms of like the global work um, with a little bit of funding, not very much from the Open Society Foundation. So we did the kind of like, we thought, okay, if we have done this kind of like work in the UK and it has been taken on in mainly higher income countries, can we kind of like think about producing similar evidence for low middle income countries? And so that's where the work started. And we kind of did the similar kind of like cost impact work, but also return on investment work, or sometimes I call it cost benefit analysis work in 4 countries at that time. And that kind of like went on for a couple of years. Also, the COVID pandemic happened. And then we had this kind of like more opportunities to kind of like do a bit more work with Thailand in particular, and really thinking about how we can take the methodology so that it becomes more kind of like something that's scalable and can be used by countries themselves rather than us having to kind of like do all the work, because we did find that there's quite a need of that type of economic evidence. And so we're going to kind of cover mainly today the cost impact work, but just to make you aware that a lot of other work has happened over the time. And so there's also a lot of work that happens, for example, more kind of like opportunistically as kind of like projects come up. So I should mention STEP CIE, led by Janet Milgram, which has been like introduced as part of the Gold series as well previously, and the Chime project led by Lauren Stewart and Sarah Skeen, which is taking place in 3 African countries at the moment. And all of them have kind of like opportunities for kind of like using the economic evidence to then kind of like for kind of like wider system change. And so, who are the people we are talking about? So, it's a large number of people. And so, the logic, I guess, is a bit on the left-hand side are the people who were more involved in the kind of like later on work in terms of like the actual kind of like the current work around the toolkit and the website and that type of work and the work in Thailand. And then on the right-hand side are all the colleagues like yourself who have kind of like been involved in some of the work or might be interested in work going forward. And so, yeah, obviously, anyone can sign up. And as soon as you sign up, you're kind of like coming up on that list, which makes it then easier to kind of like link ourselves up as we develop kind of like shared interest in using economic and generating and using economic evidence in perinatal mental health. So we did a bit of a survey because I guess one of the things like we weren't obviously quite sure of like if there's actually interest in those resources and how we can kind of like best help people to use them, but also just think of like how people might want to use economic evidence in that field more generally. And so it's quite interesting. So I think a lot of people want to kind of like use this type of evidence for research and grant applications, which makes a lot of sense. We have seen that being used in quite a lot of applications, and it's often kind of like also referred to, for example, in yeah, in papers that are kind of like publications that are kind of like making the case for perinatal mental health investment or are just highlighting the importance of the topic. Um, and then obviously advocacy and campaigning, which is exactly what this is meant to do. So that's great as another kind of like way of using it. Should I click this away? And in terms of like the kind of like aspect of the economics that you think you're interested in, So quite a few people are interested in the kind of like cost work that we're talking about today, but there's actually also quite a lot of interest in just economic evaluations more generally in that field and how we can maybe design it, how we can kind of like find ways to maybe find a more kind of like shared methodology and these kind of like things, which we definitely would like to cover as well in kind of like future webinars and knowledge exchange activities. And then interestingly enough, there's also quite a bit of interest in prevention and early intervention, which is really nice. So there are some projects that I know of that are hopefully producing some really nice economic evidence, like the CHIME project, for example, in the Gambia and South Africa and Lesotho, in that kind of like field of prevention. And so that's really exciting work, and we should be definitely wanting to focus on that. And we just started a study as well that is in the UK on kind of like prevention in the third sector. So hopefully there will be some kind of like really shared kind of like interest in talking about it. And then in terms of the people who are in the network, so we have quite a wide range across really the different audiences, from researchers to policymakers, people with lived experience, which is really fantastic. That's exactly the audiences we want, and hopefully more of it as we go along. And then quite a good focus on early career researchers, which I think is so important because obviously there will be people who are new to the field and helping them to kind of like link up quite early on and understand like, who are the people they can connect to, which is like, yeah, really a really important thing to kind of support. And then maybe just the final thing. So yeah, people are interested in the kind of like cost calculator tool, how to use it, but then also really the case studies from the countries. And so that's what we are focusing the next webinar on. And yeah, people like Simon Honigman and a whole range of colleagues will kind of like report on it. And I'm going to kind of show you who's presenting next time at the end of the session. But yeah, maybe I should also say that there's what I found quite amazing. There are quite a few people who actually, and some of whom I know, who are going to present on the economics themselves and just telling us how they use economic evidence in perinatal mental health. Not necessarily just using the tool, but just more generally, which I think is really fantastic. Okay, great. Just trying to. So just a quick overview of the economic evidence that we can use to inform decision making. So there are different types of economic evidence. Just one slide, so I'm sure that most people of you know that. But just as a reminder, so we have different types of economic evidence that are useful for different type of decisions. And so cost of illness or cost impact studies, they basically are the studies that we are talking today about a lot, which are examining the disease burden, and they're mainly meant to kind of like raise awareness of the overall impact. So they are the ones that that's the information that decision makers might need to decide if they're going to invest into an area at all. And then the second type is cost effectiveness, cost utility, cost benefit, cost minimization analysis, a whole range of different types of analysis. They're all slightly different with regards to how they're kind of like measuring outcomes, but they have in common that they're really much more about, like informing decisions about how to invest. So not whether to invest, but how to invest. So once the decision maker has made a decision that they do want to invest in perinatal mental health, how should they actually invest into it? And is it worth it? And then the final one, which is sometimes quite related, is the one like, is it actually affordable and is it cost effective at a scale? And so that's the kind of like thing that's often a lot more kind of practice relevant in my experience to decision makers. They want to know how much money they're supposed to be spending on something, and then what are they getting in return. Yeah, and obviously each of the types kind of requires different kind of decisions, and it's really quite important to be aware of that because not all of that is always, especially in more kind of like complex areas, some of those decisions are really not by the book, right? Like, so some of these decisions are made or should be made, at least in my opinion, by experts in the field, like what kind of costs to include depends on the decision problem. It's not just, like a black and white kind of like answer. It's like it's a decision you have to make. And the time horizon is short term or is it long term? The outcomes, as I mentioned, and also like even things like discount rates. I mean, there's some recommendations and there's less kind of discrepancy, but all of this still needs to be decided. And so that leaves the opportunity for and need, I think, for a lot of kind of expert involvement, which I'm going to talk about in a moment. And obviously, depending on those choices, the findings also look quite different, which is sometimes where economic evidence gets criticized for, understandably. So next, so I'm just going to present a bit of an overview of the kind of like current research that we have done and the policy work, and just to give you an impression of what's available. So this is just kind of like just a kind of like background as to why we're doing this work in the first place. So obviously we know for perinatal mental health that it has these kind of like short-term and long-term impacts on mothers and children. So we know it's affecting 1 in 5 women or mothers and other birthing people. And we know that there are kind of like the shorter term impacts on infants, starting from, even when they're not yet born to when they become, when they kind of like grow older, and ranging quite widely from, like initially kind of like, I don't know, being at high risk of kind of like low-term birth and being born preterm to all sorts of challenges longer term with nutrition and breastfeeding related, and then kind of like longer term impacts related to cognitive and physical mental health problems, which then kind of like go into the longer term and include even things like school attendance. And all of this is now kind of like quite well established. So we have like over 100 studies, I think I counted them at some point, crossing a whole range of like altogether like 6 million women, and with like long-term follow-up periods. So there's really kind of like not a debate about the impact. And that's the kind of like evidence we used in our kind of like cost of illness work that we did in the UK initially, basically using all that kind of like data from birth cohort studies, and then kind of like modeling the kind of like short-term and long-term costs on children and mothers and children over time. And some of those costs are related to the government, but even in the UK, it's a fairly small proportion. There was 20% related to things like health and social care, education, and criminal justice costs, and then wider societal costs, 80%, related to kind of like losses in quality of life that we valued in monetary terms, productivity and income losses, and we even included things like out-of-pocket expenditure. And so altogether, that kind of like came up to that kind of like 8.1 million, which refers to one birth cohort. And so that's the kind of like number that's quite often cited, that I'm sure you have seen, some of you have seen in policy documents. And it's just important to bear in mind that this is obviously stemming from evidence, which is kind of like international. So it all plays out slightly differently in different country contexts, which is quite important to consider, and means that there's more need for kind of like country-specific analysis. And that's in particular the case for kind of a common perinatal mental health problem. So for more severe conditions, the impacts are probably quite similar, but for common mental health problems, they're actually quite different and vary between country contexts. And so I think that's really important to bear in mind, that, so this highlights the kind of like complexity and the kind of like relationship that those kind of like factors have with social determinants of maternal mental health. So things like poverty, gender discrimination, substance abuse, lack of social support, violence, natural disasters, and conflict. All of these factors are influencing prevalence and impacts on the mothers, but also on the children. And especially for kind of like things like stunting, it's really quite important to be aware of the differences. Like stunting has a particular importance in some low-middle income countries, and there are studies that are showing that maternal depression is responsible for 3.2 million cases of stunting. So it's just that kind of like one child outcome is related to a lot of cost per birth cohort, is that. So you can find the kind of like estimates for that in the study below by Smith and Farsi, which is like a really great work to refer to in that context. Okay, so maybe just going back to, or just kind of like explaining a bit about the approach we are taking in that kind of like cost work. So we decided basically, and I think that's a common problem, that economic evidence is not kind of like used necessarily by decision makers. So even though it's kind of like viewed as important, actually a lot of the kind of like evidence that comes out of, for example, from cost effectiveness studies is not actually being taken up that much by decision makers, or not as much as we want them to in some ways. And there are definitely reasons for it, and often it kind of like misses the relevant problem. It doesn't kind of like reflect exactly the needs for the decision maker at the time, or it might not be well understood at that time, or they might have a different view on, for example, some of the decisions you made around kind of like cost or benefits and what's really important to include. And so that's a bit the logic that we have like in our mind when we think about involving experts in economic evaluation. And there's an increasingly kind of like recognized need for involving experts and then also wider stakeholders in economic evaluation. And that could be kind of like really thought of quite differently. So it's not like a right and wrong approach, but we actually involved experts from the scope of the analysis, for example, in the kind of like cost modeling, really from the start, and kind of like thinking about what kind of like conditions to include, letting them kind of decide about some of the parameter choices, the data sources. Sometimes they even kind of like produce additional data if they could from, the secondary data often, or even using some of the unit cost. And also helping with kind of like wider stakeholder engagement. So sometimes the people that we work with, they might themselves have kind of like already established relationships with stakeholders in the field and policymakers. So they are almost like taking on that part forward, which is amazing, and kind of like getting the evidence out there, if you like. Um, and also helping with the contextualization of findings. So that part is really quite important. Like findings can be presented in so many different ways, and we are trying to kind of like work really on making sure the findings are presented to kind of like be aligned with kind of like policy priorities. And I can refer to that a bit later on. But here you can see some of the work we have done in the different countries with colleagues. So they are our kind of like experts, but a lot of them, as you can, if you recognize them, you might know, have obviously kind of like doubled hats on. So they're kind of like researchers, but they also might be kind of like advocates, they might be practitioners. So they're really different, kind of like, they have often, different kind of like roles they're taking on. And those kind of like relationships are really fruitful, and they're helping kind of like with kind of like wider stakeholder engagement, if you like. So it's really becoming like a community in some ways over time. And the latest work, so this is like the work we did, the published kind of like work we did in South Africa, Brazil, and Pakistan, and Malawi. And then we're currently doing work in Thailand that I'm going to kind of like explain a bit more about later. So this is a really good way of kind of like maybe just showing of where and how kind of like cost impact data can be used internationally, how they're being used. So they have been used definitely in kind of like maternal mental health policies. They're often used, if they're not named in policy documents, they're sometimes used, for example, in briefings or in kind of like the material that then kind of like informs policy change. So often by kind of like charities or NGOs or networks, in particular the maternal mental health alliances that exist globally. And so this map is taken from the Global Alliance for Maternal Mental Health, and Ellen is in the room to kind of like comment on it. But it's not updated. I'm sure there's a later version, Ellen, but it just shows the countries where kind of like policy already exists in perinatal mental health or maternal mental health, or if it's mentioned, or if there's no policy. And I think some of the countries have already moved to green now. So definitely, for example, Ghana is now green. So that's brilliant news, I think, from the last 2 weeks or something like this, that they have developed a maternal mental health policy, which has been launched, which is amazing. And then there are other developments as well that are really important. And you can see that, for a lot of these countries where there is policy change, we also have produced kind of like, or someone has produced these kind of like cost values that can be then kind of like cited, even when the policy already has been introduced without the cost figures. It can be still very important to then have the cost figures later on, if you like, because at some point the governments might have to back up on that policy. And for sustainability reasons, it's still useful to have those kind of like cost data. I don't know if Ellen is available if you wanted to comment, if anyone else wants to kind of comment on any kind of like changes that happened, because I'm sure we haven't captured all of the work that's being done right now. Okay, otherwise I'll just continue. So that brings us to the kind of like findings, I suppose. So this is just kind of like the findings we have from the different countries. This is like the work we produce with that kind of like fairly similar methodology over time. It's always a slightly different because you're kind of like learning over time. So it's not as, it's not sometimes as standardized as you want it to be, maybe. And because it's country specific, you're making more adaptations. Oh, there's Simon, I think.
Uh, Thanks, Annette, for asking for input at this point. Just wanted to quickly interrupt. Apologies about this mapping. We are, many of us on this call and others are going to be updating a sort of ecosystem mapping with a focus initially on Eastern and Southern Africa, on what people are doing in maternal mental health, what the policy environment and the other sort of contextual environments look like. So we're hoping that this map will be updated. We'll be seeking out information from different countries, hopefully other countries over time, which will be useful, and particularly looking at health economics data that or indicators that we can try and source that might be used in future for health economics data. So this is a quick call out at this stage. If you are in the Eastern and Southern African region and you would like to be considered to be part of our mapping exercise, our ecosystem mapping exercise, I'm going to pop my email here in the chat. Please reach out. We're going to be doing that in the next few months. Thank you.
Amazing. And Simon, you demonstrated how the use of this network is supposed to be like exactly for that kind of like sharing. So please, if anyone wants to come in with similar kind of like shout outs or like, just come in. But obviously we will try to kind of like support networking throughout as well. But yeah, this is amazing. And it links so nicely to the work thing.
And Annette, Allen here.
Yeah.
Hi. Just to say that there is a slightly updated version of the map on the GAM website, but that is also currently being updated. So it's a much simpler exercise than Simon is undertaking for Southern and Eastern Africa, but it at least gives a global picture that has some degree of accuracy. But if people have more information about their countries, please do write into us, email us at info@gam.org.
Right. Amazing. Thanks, Ellen. Yeah, so just showing you again like the findings we produce from the work. So that's kind of like helpful in some ways because obviously over time, the more data we're getting, the more we can populate the map, but also it's really nice to kind of like highlight some of the differences in, for example, paper publications. So we then kind of like start referring to how that figure relates to findings from some of the other countries. And a lot of that, I mean, like you can see that figure in Pakistan is being challenged in some ways a little bit because it's so high. It's like it's such a huge amount of billions in comparison to some of the other countries. But one of the reasons, for example, is the prevalence rate is one of the highest, and the birth rate is one of the highest globally. So there are kind of like reasons why these figures are blowing up so much. But it's still kind of like, and for example, in Thailand, we find that among the kind of like low and middle income countries, the cost per woman giving birth in US dollars is the highest, and that's explained by just the kind of like higher incomes. They are kind of like a higher middle income country, and so that's reflected in that kind of like higher value, if you like. So yeah, there are kind of like differences, but also like similarities, and like as you're producing these findings over time that are kind of like useful to then kind of like explain to people and talk about it, and just kind of like start the discussion often, which then leads to kind of like more interest and more kind of like ideas for evidence gaps as well. So obviously none of these figures are perfect. They're just kind of like estimates, and they're based on a lot of assumptions as well. And I'm sure we're going to talk about assumptions a lot more as we're kind of like going through this. So this is like the more technical part, but I think that's the part that people wanted. So I hope it's okay to be more technical, but I'm not trying to kind of like explain everything about that tool. But I do encourage you, if you are really interested in using that tool, to just get in touch. I should have mentioned when I said we have funding for it. So we don't actually have funding for all of that as such. There are these kind of like small reports that become available as and when we kind of like go along, and sometimes they kind of like stretch over a few months and sometimes a year, but not in any kind of like very substantive way. So that's definitely one of the things that is a bit of a limitation, but I will help as much as I can to kind of like support your costing work if that's what you want to do, obviously. And yeah, and any ideas for how we can kind of like as a group kind of support each other is really also appreciated. Yeah, so this is just kind of like why we would actually have those tools in the first place. And it might be obvious to some, but maybe just to kind of like say, so it's basically a way to kind of like have, you know, produce those kind of like economic findings relatively quickly. And so it's really allowing us to kind of like for other people to use that tool. And maybe it helps to move towards more kind of like an agreed approach of what kind of costs and benefits to consider in this field. So especially this kind of like focus on, you know, the society and intergenerational perspective, even though for some of us it might be really natural to think in those terms, it's not necessary for every decision maker, right? Like a lot of decision makers are much more concerned about short-term budgets. And so having this kind of like much kind of like longer-term argument of how you should be considering these kind of like costs for mothers and children, it's and including things like quality of life and things like that. All of that needs to be communicated. It's not uncontroversial. And so doing it together as a group is obviously it's just kind of like easier and makes it stronger over time. And it's just kind of like hopefully build some kind of momentum for future research and in particular kind of like maybe an understanding of what kind of like economic valuation research is really needed in that field and who of us might want to get involved in that as well. So before we go to the kind of like cost calculator tool, I just want to quickly mention, even though we have spent less time on it, but there is in theory a tool available that kind of like is a bit of a proof of concept cost benefit tool that we developed for scale up integrated care of maternal mental health screening and then kind of like lighter or low level, low intensity kind of psychological treatment. And so that's available via that publication. And if you actually kind of look carefully, you will find that the whole tool is actually available. In some ways, it could be used and it allows you to kind of like change some of the parameters around who should be providing it and things around some of the delivery methods and so on and so forth. It's not very kind of flexible. So you can't change a lot of parameters at the moment because it was just meant as a proof of concept work that we developed with colleagues in Malawi, which has been really, really helpful. But it kind of like shows, for example, in this instance, we have like assumed that there is a kind of like midwife providing screening very quickly because there wasn't enough, like the stakeholders decide there isn't a lot of time to do the screening. And then a volunteer coming in and providing more intensive or more kind of like lengthier training, screening, and then also like treatment or some kind of like form of counseling. And so you can see if those kind of like parameters are assumed, then there is a bit of like initially a negative kind of return investment in the first kind of like years, and then it becomes like a positive return investment over time as kind of like you have kind of like efficiency gains realized. And so that's a kind of like tool we could also think of developing, for example, as a group more. I know that there are some people in this room at the moment who are trying to think of those things for example, the Chime project, but also other kind of like interventions. And obviously that kind of like integrated care model is exactly what WHO kind of recommends. So there is a lot of opportunity, I think, to think about whether one wanted to kind of like think about a more kind of like shared approach to having a kind of cost benefit evaluation of integrated care in different countries. And quickly, so this is just another example. It's not a tool, I should say, but it's still maybe a useful resource for those who kind of like want to think about doing this type of analysis for integrated care. So we did that work in the UK, again, funded by the Maternal Mental Health Alliance, and Ellen was heavily involved in that work as well. But it's just, basically kind of like making the kind of case for investing into increasing access to treatment for women with common mental health problems, so who are kind of like estimated to not kind of currently receive treatment, and where we know that they would benefit from at least kind of like low level or even kind of like more intensive kind of psychological or psychosocial treatment. And has a lot of information also about workforce implication at a kind of like national level, so that's at the UK level, and including some kind of like case examples as well of how that kind of like model is already implemented in some localities in the UK and how much it costs and exactly like what kind of like staff is involved. So it's had a lot of information in there. And it's really, I think, just useful maybe for future learning in particular to kind of think of if we want to do something similar in some other countries. So that's the kind of like toolkit, how it looks like. So you might have been on that website, so the GEM website. And again, like this is just kind of like work in progress. And we want to kind of like adapt that tool with you or with colleagues who are using the tool over time, so it becomes better, easier to understand. We might produce some additional resources, but this is how it looks like at the moment. So you might want to kind of like go on the website if you want to know, or try it out later if you haven't already done so. There's some kind of like terms being used like DALI, so that's disability adjusted life years, GDP, gross domestic product, MMI is used for maternal mental illness, and PMI for perinatal mental illness, relative risk, RR, and then you have the years of life lived with disability and years of life lost. And we are probably going to work, obviously there will be technical terms that kind of like need a bit more explaining, and not everyone will understand it. So we are quite aware that this might need some more kind of like translation work for some people as well. And any kind of like suggestions around how to best do it would be really appreciated as well. And we know that there's already some work done that we could probably refer to. But it just helps to know if like people think it's really important or have ideas of how to best do it. And so this is just kind of like the modeling approach we took in that kind of like toolkit, basically, whereby we have kind of like, which I'm going to show you in a moment, 3 key resources. But this is like the overall approach, kind of like showing you of the logic of how we are modeling it. So we are starting with a kind of like cohort of women giving birth. So that's kind of like starting from pregnancy, and we are considering even things like stillbirth, just to make sure that we have the number of women included who are pregnant, because obviously there's no number, well, I'm not sure if that's, maybe it's not obvious, but there are no data at the moment on kind of like women who are pregnant or birthing people who are pregnant, but there are data on live birth. And so in order to kind of capture, for example, women during the antenatal period, we're then also considering stillbirth. We're also adjusting for maternal mortality throughout the whole cohorts for all the population. I should say we're considering mortality. So you always kind of like consider that some people might be not necessarily dying because of their mental health problems, but they're dying from kind of like natural causes during that time. And then from that kind of like birth cohort, and so the kind of like hypothetical model of women giving birth, we're then kind of like modeling that proportion of women who then develop anxiety and depression during that kind of like perinatal period. And so we are kind of like having these kind of like separations or distinction into depression and anxiety, whereby we need to make sure that anxiety is just the proportion that's experiencing anxiety without depression, to not double count. And I'm going to say more about double counting later on. And we're also kind of like including society. But yeah, it's a bit more challenging because obviously the data are not very good. So often that's kind of like more for additional sensitivity analysis. And then from those women who developed anxiety and depression during antenatal and postnatal periods, we're then modeling the women who have ongoing anxiety and depression, but related to the initial perinatal period, if you like. So it's a kind of like artificial distinction, but it's possible because there are data available on how people usually recover from perinatal mental health or from mental health problems more generally. And so those data are available, and they allow us to kind of like develop probability of recovery, if you like. But we're assuming that by year 10, no one has any kind of like problems that originate to the perinatal period anymore. So they might obviously have, because they might have already had problems before, or they might develop mental health problems unrelated to the perinatal period, but we wouldn't account for that. We are only interested in that proportion that is still having kind of like chronic symptoms, if you like, over that kind of like 10 years period. And all of that is kind of assumption based, but it's kind of like a way of looking at the world that is hopefully making sense and has made sense to most people who are kind of like have been our experts over time. But it can be challenged. Everything in some ways like can be challenged. And then we have the children with problems that are basically again like a small subproportion that are basically the children exposed to perinatal anxiety and depression. And again, we're separating that out by anxiety, depression, and we're separating that out by ante and postnatal period. And that's because the way we are getting the evidence from those cohort studies is presented in those ways. So it allows us to kind of like include the data for those periods, for ante and postnatal periods separately. And yeah, so that's basically the overarching rationale. And then you can see later on, I'm going to show you an overview of what kind of outcomes we're exactly including at what periods. And then obviously there's a way by which we kind of like need to attach a value to these outcomes. And so we are going by kind of like approaches that have been suggested by WHO and other kind of like economists in the field. And it's basically kind of like valuing DALYs with a GDP per capita value. So that's like half of the value of GDP per capita that's kind of like assigned to a DALY. That requires to attach what we call disability rates, which are taken from the Global Burden of Disease study, which is produced by the WHO. And it's kind of multiplied with a period over which these kind of like conditions are occurring or hypothesized to occur or estimated to occur. We also have the kind of like years of life lost concept. So there's already like an established kind of like lifetime value, which is what we call like a net present value available just for that, for the eventuality that people might die during their perinatal period. And again, we have to be quite careful with that estimate because it's obviously yeah, it's a lot more difficult to kind of like think about attributing suicide during that period, especially to kind of like more common kind of perinatal mental health problems. And then income losses is usually, so there are different ways of kind of thinking about how to assign income values, but the way we've done it is like we're just using an income decrement for those with mental disorders versus those without. So there are these kind of like studies, for example, that show that not just women necessarily, but we're trying to get data on women who have mental health problems are less likely or have a lower kind of like probability to either be in employment or to have certain, or they just have lower earnings. And so we're using that type of data. An exception is stunting, which has an established kind of like net present value for income. And so that's what we're using. And then healthcare expenditure, in some ways, it's quite straightforward because we're really only including infant hospitalization because that's where we find that most of the robust evidence sits. And so it's only like requiring a kind of like unit cost for hospital treatment for certain kind of conditions, which I'm going to show you in a moment. So before I go on with the kind of like more detail on that, so there are three kind of like key resources that I wanted to mention that are available at the moment that we produce. And again, all of them, if they're not making sense or if they need improvement, we're really happy to work on that if and as time allows, but hopefully they're already a little bit useful. So there's a kind of like cost data input template that you can find directly on the website quite easily if you go under how to generate these estimates, and it's also like on the toolkit itself. And basically has a whole kind of like table of the data that are required for the model. And they can then kind of like directly also inform if you wanted to publish the findings, the table. So it's really good to kind of have that kind of like template. And that's also the template that I sometimes use as at least as a starting point when I kind of like ask expert to comment on helping with some of the parameters and making almost like validating some of the parameter values. And in some ways, like if you have some experts that are quite kind of like in tuned with that kind of like way of thinking, you might even just share the kind of like template with them. The second one is the actual cost model. So that's the kind of like, an Excel document, and I'm going to show you a bit more how that looks like. But it's basically the underlying structure for that kind of like toolkit that you can see. And so that's where all the data are. And it can really only be changed at the moment by LSE. And so we're quite kind of like stuck to that kind of like structure. So we can't just include, for example, just an additional child outcomes easily. There is a structure that's now kind of like there, which is a bit unfortunate, but it doesn't mean it has to always be exactly like this. We try to make it as useful as possible for the moment. But, if there is more funding, we can think of changing it and including more conditions or more outcomes as as evidence becomes available, I suppose. So we this is all based on our work, on our understanding of the literature as we know it, but it's not always updated immediately. And then the cost calculator tool is basically just the interface, right? So that's the part that's gets populated by the user once you have all the data compiled, and not all data can be changed by the user. So it would just be too complicated if you had a field for every single parameter that could be potentially modified. So there are only some options for changing the ones, and I can explain a bit more the rationale for how we chose those options. And again, some of that can be changed. So if there is something that you feel, oh, I actually think that should be changeable by the end user, then yes, there are ways of making that happen. So this is just the cost data input table, how it looks like. So it has all the data that are required, as I said. Some are directly observed, and some are derived estimates. So you actually need to do some calculations, unfortunately. So it's not as, it should be hopefully relatively straightforward, but some of it does require making some of additional calculation. And usually I then have some kind of instructions provided on how you can do that. But if something is not clear, again, just feel free to get in touch. I'll try to explain it better and maybe then change the cost data input template over time. It also has a sources. So some of the data obviously quite easy to get because they're published, stillbirth weights or live births or GDP. There are certain things that are just really easy to find. And so in those cases, there's quite often already a data source. Even for some of the child data, for example, the relative risk, you might not have the country-specific estimates, so there are already estimates included, or suggestions for estimates, or at least the data sources. Yeah, so hopefully that makes sense. And so this is just the overview of all the different types of data you need. I hope it's not too overwhelming, but obviously, the data does need a substantial amount of data on population estimates, and then the maternal parameters around mortality and prevalence of the conditions, the child cohort parameters around the relative risk that I mentioned, but you also need the prevalence. So you need the prevalence of every child outcome that you decide to include in your model. You need to know the prevalence of that child outcome. And I know that has already caused a little bit of confusion of how to make that decision. So I'm going to say something a bit more about that in a moment. But you obviously have to make a decision at some point about which child outcomes you want to include. And it all has to be informed by the evidence and where you feel you have substantially enough evidence. So you never need to feel like you have to include all these different child outcomes, for example. It's just then it's driven by the available country-specific evidence. And then you have the cost and economic parameters, which again, they should be fairly straightforward to collect, but sometimes they do require a bit of additional adjustment. For example, the cost of hospital treatment for certain child conditions. And so this is the cost model structure. It looks quite a lot. It is quite a lot. That's why it looks quite a lot. But you have the it's basically 3 sheets. I think that's the easiest way and that's really what it is. So that's the best way maybe of just saying it. And one has all the inputs from the data input template are basically in one sheet. And that's obviously quite a lot of data around all the things that I mentioned before. And then you have another sheet that's the calculations. So that's where all the inputs are basically then kind of like linked to generate these kind of like annual values. But they're still quite distinguishable between like, every single kind of like outcome or like every single kind of like incident. They're still presented differently for mothers and for children, and by each of the kind of like parameters in terms of like DALYs and income losses. So they're all kind of like still presented all by year and all, distinguishable by the kind of like different like conditions, for example, by depression and anxiety, and by the different kind of like child outcomes. And they're all therefore kind of like treated slightly differently in how they then kind of like enter the total value, if you like. So the total value, the total aggregated costs are then presented in sheet 3. So that's basically where you have everything kind of like in some ways, aggregated together. And that's almost like the findings as you then kind of like present them in your publication, if you like. So that's where you find like all the DALYs for depression, anxiety, aggregation, and even suicide, if you like, although they are still kind of like split. So you can consider them separately in sensitivity analysis, the income losses, and for the children, the DALYs and the income losses, as well as healthcare expenditure. And then obviously you can aggregate them across the mothers and the children. They're already aggregated there as well. So this is just more detail. I don't know how much more detail I should be getting, but there's a bit of time, so maybe I just continue, and if any questions, just let me know now. But this is just more kind of like giving you an idea of what's actually really included, and that kind of like technical detail is quite important when you actually kind of like really want to use that toolkit, unfortunately. But basically the logic is that you have for mothers outcomes, you have the depression, anxiety, whereby anxiety is without the co-occurring depression, and that's a kind of like ongoing period. So 1 year starting from pregnancy to 10 years, and you have the DALYs and the income losses modeled, and then you have this kind of like one value that is presented in DALYs, years of life lost. And then for all the different child outcomes, so this is basically all the different outcomes you can potentially include. You don't have to, but they are possible to include, but for different time periods, depending on the evidence. I should always emphasize these are the kind of like choices we made based on the best evidence we had at that time. So it includes, I can just quickly go through it, preterm birth and low birth weight, hospitalization. So that's like infant hospitalization during the first year, infant diarrhea, asthma and wheezing, infections, stunting, wasting, conduct disorder, attention disorder, and emotional disorder. So these are the outcomes for which we, across the different countries, we found evidence. But again, it doesn't mean for every country you find that there's an impact, but there is potentially an impact. And so you have to explore if for your country where you want to do the analysis, you feel there's enough evidence that these outcomes need to be and can be included. And for some of these outcomes, I should just say, like they are short-term outcomes, and sometimes we force them to be shorter term than they actually are. But we force them because otherwise it just becomes too much complexity to handle in a model. So for example, for things like low birth weight, hospitalization, diarrhea, asthma, you can only really include the kind of like healthcare expenditure, for example, for that kind of like first year. So if there were to be more, if you already have evidence, or if you would have data for healthcare expenditure beyond the first year, you probably want to include it by kind of like providing a net present value. So there are ways of including it anyway in the model, but this is kind of like forcing it to be manageable within the kind of like model structure. And then the other outcomes that are kind of like modeled over the whole kind of like period of, from when the child is born to the 40 years. And that's mainly kind of like, things that are really matter more in terms of like long-term outcomes. So definitely stunting, wasting, conduct disorder, attention disorder, and emotional disorder. And then there's another overview table of how exactly what can and cannot be addressed in the model. And again, like it's all based on what we found in the literature. So there's not necessarily the complete logic to all of it. It's just like for certain things, for example, stunting doesn't have a kind of like disability rate. And to be honest, I don't even know exactly why that is. It just doesn't. So the global burden of disease study has a disability rate, for example, for stunting, but for wasting, but not for stunting, which means we can't include it. So they're sometimes quite kind of like, yeah, they're kind of like reasons that are not necessarily logical as such, or there might be a logic that I don't know of. I don't know if anyone in the room knows why there is no such disability rate for stunting. I'm sure there's a reason, but it's not necessary that I always know the reason. But this is what we kind of like are able to include. I don't know if anyone wants to come in and provide the perspective on including outcomes.
Why not include learning? Sorry.
Learning?
Yes, learning. Because there's lots of evidence that cognition is affected as well. And learning has a long-term effect on the child and income, on their development, their success in life.
Yeah, and we had actually evidence from the UK, which was, kind of like directly allowing to include much more around learning outcomes and cognitive outcomes. In low middle income countries, we only have really that clear evidence for quantifiable evidence for stunting at the moment, which I kind of assumed includes, I always kind of assumed that has a lot of kind of cognitive impairment implications, and that's the way of how it's kind of like indirectly included.
But I think that there's only evidence for stunting because it hasn't been looked at. I'd be very surprised if it's not the same, because the mechanisms are likely to be the same as in high income countries.
Yeah. No, that's really helpful. Yeah, and I think like all of these outcomes, like, if you go through them one by one, the more you look at them, you kind of think, oh, wow, this is really limited. But it is really what the evidence, like what is so, like for example, like diarrhea, asthma, wheezing, this is all infections. These are all the kind of like birth cohort studies that we found at that time. But yeah, as we go along, we might just find better data. No, sorry, that's a question.
Right. There are two questions in the chat. I don't know if you want to get to them after the presentation, but also Simol just wrote, stunting should definitely have a disability effect. I'm surprised it does not also preterm birth based on how preterm. I'm also surprised it is one big category. The effect varies a lot if it is 36 weeks or 29 weeks, for example. And then just let me know if you want me to read out the other two questions or if you want to wait till after. Yeah?
Yeah.
Okay. So the first question was from Claire, and it said, how much more difficult is it to calculate cost of effect, not just on the children's whole lives, but the grandchildren's whole lives, as so hard to estimate costs 2 generations in the future?
Yeah. Yeah, that's really interesting because there's actually, I think Ellen and Claire and other people mentioned that there's this kind of like, I think there's a bit of evidence on the grandchildren. I'm not sure if it's quantified evidence or is it?
No, there's not much evidence yet. We're about to start looking at it, but
Okay.
I think the evidence will be coming, but I don't think we have it yet.
Interesting.
I'm sure there's lots of evidence in rats and mice and so on, but in people there isn't much evidence yet.
Mm.
Okay. Should I go to the second question?
Yeah, I mean, I'm sure there's anecdotal evidence, right? That's why I think Claire's probably mentioning it, but yeah, maybe not yet the quantified evidence.
Can I make another point then? I don't know if he wants it now, but we should really be looking at fathers as well. It opens up a whole new career for you, but certainly postnatally, fathers have a big effect on the child, and the whole perinatal mental health of fathers we should consider it, and the economic case will again help to make the case.
Yeah, actually, this has come up a lot by not just policy advocates, but even like some of the Department of Health and Social Care in the UK, that they wanted to include evidence on fathers. Again, like I'm not sure we're quite there yet in terms of, because it would kind of require cohort study data, right? Like where you actually have long-term evidence on child impacts linked to directly fathers' depression. And unfortunately, my understanding is that some of those birth cohort studies, they haven't specifically included the fathers, but I'm not, again, like I'm not an expert. Is that right, Vivet?
Yeah, we've just actually published a paper in April, which I can send you, which shows the effects of fathers up to the children being age 24. The postnatal effects of fathers, not antenatal, because it depends on the outcome too. But effects on a child's the offspring's depression is very clear for postnatal effects of fathers, and the fathers themselves need help. So I think you've got a lot more work to do. You're not going to be short of things to do. I mean, I think it's brilliant what you are doing.
Thanks for that. Yeah, I do wonder how the father's perspective, how that impact. I can definitely see that in a kind of like UK context being really important at the moment politically as well. I don't know how that plays out in a kind of like low income country context. That would be actually really interesting. If that would convince policymakers more if you were.
Yeah, I know the research is only high income.
Yeah, it might.
Should I ask the second question?
Yeah.
So Simal said the model includes women with pregnancies that end up with birth, including stillbirth. Right. How would the model change if we were to include women that experience miscarriages or fertility challenges?
Yeah, that's another one that I think is just, yeah. I think it has come up a lot as well in terms of where government wants to know more about, isn't it? But I don't know if it's can be easily included. I haven't looked into the evidence at all, to be honest. Do we know anyone? Does anyone know what kind of evidence is actually out there of the specific impact to women and birthing people experience life children's loss? I assume that's during or before, yeah, birth or after, but not necessarily subsequently.
I think there is a fair amount of evidence, but the sort of mental health conditions or challenges that these women experience are often not grouped together with those experienced by mothers who are have live children. I think typically it's considered sort of in a different realm, but I could be wrong, and maybe that's not necessarily appropriate. It'd be interesting to hear your thoughts on that, Simal.
Yeah, so first of all, fantastic presentation. Thank you so much for this great discussion and great work. So yeah, we know that it definitely increases the risk for subsequent perinatal mental health if if a woman has experienced miscarriage or fertility challenges. So there is that compounded impact. In terms of the actual numbers, I think you're correct. I missed who just made the prior comment. I don't think like they're included under the perinatal bucket, but I think many in the field is pushing for those to be also included in the perinatal mental health bucket because they are related to perinatal mental health in every aspect, all the failed pregnancies and also all the fertility challenges.
Very interesting. And Senabo, do you want to come in as well?
Yes, thank you, Annette. Yeah, I just wanted to say regarding the reproductive loss and infertility, I think it's kind of being, in my view, a bit left out of the discussion in a way, but some people have done some work on it. And I think back when I was trying to apply for my PhD, I just did a bit of a quick literature review on that, and there is some links or some evidence around it. A scoping review that was done for psychosocial aspects of infertility in African countries in 2024. I think it was published by Romani and co. Yeah, it kind of mentioned about the impact of infertility on women's mental health. And I think the focus on perinatal mental health is very, very important, but we kind of are leaving those aspects out as well, especially with regards to reproductive loss, which is very important. And the other thing which I put in the chat is to also ask about the intangible costs in costing for perinatal mental health issues or conditions. I don't know, how is this being factored in with regards to the overall family well-being, and how can this be integrated into costing tools? Because sometimes it's difficult to quantify this.
Any thoughts from somewhere, from others in the room? Can't really see anyone in the chat. But is there anyone who has any thoughts on Senabu's question? Okay. Now, is there any comments or?
There's a comment in the chat from Ellen, which was the child outcomes disappear when the child does not survive, but it increases risk for mother in the next pregnancy. But that group will probably be included in the common mental health problem analysis, although PTSD and CPTSD is undermeasured and under-researched and may produce even more impact on mother, child, and family.
Great. I don't know if, Ellen, if you want to unmute yourself and say anything, but that's really helpful, I think.
Yeah, well, as you know, Annette, I'm very exercised from my clinical experiences with the number of women who experience PTSD and complex PTSD in the perinatal period, and the research world is really only just waking up from those. So I don't think we have sufficient robust evidence, knowing what you need in terms of doing economic analysis, yet to be able to yield very much there. But I think it's coming thick and fast. I think the clinical and research world is waking up to this group. And I suspect, knowing the impact, particularly with complex PTSD, there is probably a profound intergenerational impact, which is, of course, where most of the costs come from in many of the analyses you've done. I may have missed it, and you've probably mentioned it, but for example, in the UK, 3/4 of the costs were associated with the child when it comes to cost of illness. Can I make a separate point, though, in terms of the use of economic evidence and the way in which you've conducted your analyses in all of these studies, which is that I think it's really, really important to understand and to emphasize, you can't overemphasize it really, that the estimates that are produced are really very conservative estimates. We can't prove how conservative they are because, of course, you've analyzed the data we have, but you've left out deliberately, because you've focused on very robust evidence, you've left out huge areas where there's an incredibly high probability of high costs. For example, stopping your analyses, at 1 year or at 5 years or at 10 years. In situations where there are very likely to be much longer term effects, in limiting the conditions that you ascribe costs to, and so on. So in terms of both understanding your results, but also in terms of using them for campaigning, for example, or for persuading policymakers, it's really important to state very forcefully, these are the absolute minimum costs. They are likely to be very much higher than this, but even so, they are dramatically high.
Thanks. Yeah, and I know you always emphasize the point, and we're actually having a few slides on dissemination, so I might just move us on. Thanks, Ellen. Yeah, so this is just the kind of like tool in itself, what it actually does, kind of, which I think is now quite clear anyway, but just to kind of like emphasize, you can't change all the variables, unfortunately or fortunately. So some of them are fixed. So the fixed ones are the ones that are usually kind of like quite standard in terms of, they're already like standard approaches for valuing things, and some of the data are kind of like more globally kind of applicable data. And I can always kind of like help with more information of like, which exactly are those values and that are kind of like modifiable. I mean, you can see what you can modify obviously within the tool. I can obviously always kind of, and you can see what you can't modify indirectly by comparing it against what you have from the cost data template. But there's no reason why we can't produce more information on like what exactly is not kind of like modifiable, for example. But that's how it is done at the moment. And so you can kind of like play around with it. And then you can obviously also like always kind of like decide that you are changing parameters and explore the impact it has on the findings, which I think that's quite nice. We haven't done that in our publication because sometimes it can be a little bit unhelpful if you then have like this kind of like cost value that kind of like ranges so widely, and it's more difficult to convey that to decision makers. But usually, like one should really kind of like consider doing more kind of like that type of scenario analysis and sensitivity analysis and explore that with stakeholders ideally. So this is just a kind of like process. And I know that some people wanted that kind of like overview of what you actually need to do. And to kind of like get to that kind of like, the kind of like cost estimates. And so you kind of like starting with defining the scope, which includes in particular kind of like a decision of like, if you're going national or regional. We always went national, but there's no reason why you couldn't focus on a particular area if you wanted to. And you decide about the base year. And the base year is usually the year where you have the latest national statistics available. And so you then kind of like start with kind of like gathering the local statistics. So as I said before, like some of them you can kind of like find quite quickly some of the data that you need around birth rates and population data. And then you start kind of like reviewing epidemiological evidence around kind of like prevalence and relative risk data. And again, like some of it, you might not find the literature. So that's maybe the point where you want to kind of like start engaging with some experts and clinicians, epidemiologists, public health and policy experts, and start kind of like thinking of them as really using them to kind of like get more confidence in kind of like some of those estimates and how you should be including them in the model. So we did sometimes, for example, online workshops where we discussed it with stakeholders. And, I'm fully aware this is not always like you might be some of the experts yourself, so you might not actually have to consult with anyone because you know the estimates better than anyone. But, it is kind of like worth really checking assumptions and values from early on. And then you kind of like start continuing maybe with kind of like more kind of like data that are again, like more from kind of like desk-based searches, like cost data, GDP income, like they're not usually that difficult to identify, but you might, again, like if by the time you have identified, for example, a local health economist, as we did for Thailand, you might check with them and just kind of like see what's kind of like acceptable to use. Yeah, and then you kind of come to initial kind of like estimates, I suppose. And ideally, as I said, like test maybe some assumptions. If there is time, it really makes sense to kind of like do that as much as you can. But if you then have the kind of like final results, it's really good to kind of like at that point at least kind of like sense check with some people, who can kind of like see if that value kind of like makes sense or like, just kind of like communicating it early on, I suppose, has really quite a lot of advantages. And throughout the whole process, always document assumptions and limitations so that that's always like something you can kind of like communicate to experts and wider stakeholders later on. And then kind of like think about how you can translate the results for policy use. So using infographics, kind of like framing key messages, and then also like producing a paper publication. The paper publication is usually not anything where you achieve policy impact, but it is quite important for policymakers maybe to have that kind of like backup that you can mention, even if it's sometimes produced. I think in the UK we produce the publication a year after we produce the report that informed some of the investment decisions, but it was still always really useful to have it anyway. And then I think throughout, like, there's always that kind of like clash between country-specific versus country-relevant data. So if you don't have country-specific data, then don't think you can't do anything, right? You can still kind of like choose data that are relevant for the country context. That could be findings from the meta-analysis that is kind of like covering the whole region, or it might be kind of like from one particular neighboring country that is kind of like relatable enough. And that's usually quite a good way of doing it. Again, like checking with experts is really important. When you choose values, choose them conservative but realistic, so not too low, because that also is not really helping the purpose. And maybe orient yourself on kind of like meta-analysis and values that have been taken in some of our publications already. And as I said before, like if there's not enough evidence, especially on the child outcomes, it's probably better to leave them out. I mean, that's at least the logic we have, I think, taken. Like if there's just too much inconsistency in like how perinatal mental health problems are affecting child outcomes, or that particular child outcomes is not even an issue in your country, then it's probably just better to not worry about it in the first place and not spend too much time on it. And then always be aware of kind of like the issue of double counting. So we tried already to kind of like make that quite explicit by, for example, making sure that depression and anxiety is not double counted in terms of, you know, the quality of life losses and income losses and so on and so forth, and making sure that depression is, you know, that anxiety, for example, only captures anxiety without co-occurring depression. And again, like if you're unclear, you can always kind of like check with me if there's technical help needed, but also like it's always good to be, I think, in that sense, more on the conservative side, although Ellen might not agree. But yeah, I would go for the conservative estimate. And then the final slides, I think, are just on dissemination. And we probably will spend more time when we talk at the next seminar about country examples. And there are other people who can talk much better about dissemination, like Ellen and Simone, for example. But you can really kind of like think about working with alliances from quite early on if you're not already doing it or if you're not already part of it. And that's why you're here at the meeting. You know, there are alliances almost everywhere now. I don't know if that's true or not, Ellen. Is it true? Would every country have
there
an
are
alliance that can relate
there are
to?
26 alliances worldwide actually formed now, and about another 15 kind of in formation.
Yeah. So there will be always someone who you can reach out to in terms of alliances. And then also like explore partnerships with kind of like decision makers and lived experience voice and researchers. I think you know, like obviously if you have a strong alliance that might already come through the alliance, but if not, those kind of relationships, they're really quite important to build a little bit separately, if you like. I think consultation is always really helpful. So just kind of like really getting a good understanding of what the kind of like current policy questions are and how the economic evidence might relate to that. I think a survey might be helpful. You know, there are different ways of consulting, but it might be really good to kind of understand how those kind of like economic evidence findings might be best placed and, you know, position that evidence in kind of like, you know, in alignment with kind of like current policy priorities, which could be really quite different in different country contexts. It might be much, I don't know, like often it's more focused, for example, on the child, but it might not always be, or it might be kind of like focusing on, you know, specific issues that are really recognized problems in that country, for example, around breastfeeding or stunting or whatever it is, like cognitive development, whatever it's going to be. It might be just worth kind of like thinking about how you can place that evidence in that kind of like, yeah, when you frame the kind of like messages and recommendations, to use that kind of how it kind of like it sits in the kind of current policy context. And then always strengthen with supporting evidence. So obviously, economic evidence on its own doesn't do anything. Not that other evidence does, but you know, there's always like it's really important to kind of think of lived experience evidence and you know, epidemiological evidence and also evidence on kind of like what works. Even if you can't line it fully up, it might be still kind of like worth presenting it that way. And yeah, obviously tailoring the output to the audience. And then, yeah, I think it's always good to think about the next stage. So like, you know, as you're doing all of that, what are you actually, not just, I mean, obviously there's a question of what you're asking for in terms of like policy change, but also like maybe thinking a little bit about what you're asking for in terms of like, from an economic perspective, the next type of, or just more generally research perspective, what kind of like future research is needed. this is just quickly before we go into like the questions. An example from Thailand that we are working on, and Hamish is maybe some colleagues from Thailand are in the audience right now. So we have actually an event coming up where we are launching our new kind of like economic cost findings in Bangkok, but it's a hybrid event. So you're more than welcome to kind of sign up. And I'm sure we can share the link with you, which we just generated. But I have it somewhere, so I can put that in the chat in a moment. And yeah, this is just really showing off the type of launch event you might kind of like hold when presenting the cost findings. So this is like quite common together with kind of like a report of recommendations of actions, but also really importantly, the launch of the alliance that is taking place in Thailand, the Maternal Mental Health Alliance. It's not called Maternal Mental Health Alliance, it's called the Perinatal Mental Health Alliance for Thailand, I think. Is that right, Hamish, if you're listening?
Close. Perinatal Alliance for Mental Health Thailand.
Amazing. Yeah. Did you want to add anything in terms of like the Thailand work or like anything you wanted to say?
No, I guess I'll just add thank you for all your work and support, and Alan. It's been a long journey getting the alliance set up, obviously starting from scratch in Thailand, but with sort of drawing on all the different pieces of research from yourself, and then you mentioned others supporting evidence like the epidemiological studies. So it does take a while, but trying to get everything lined up does help. I think pulling the evidence together to get people on board and to show that how big the issue is and that it's an issue that needs addressing. And I guess this is all sort of culminating with the event next month, where we can talk about some of, in addition to your work, the work with Perinatal locally, looking at their study along with launching the alliance. And we've had some good calls today, lining up other alliance members across the board, from psychiatrists, OBGYs, pediatricians, etc. So just a big thank you to all your support.
Thanks. Yeah, no, it's really great. Thanks for mentioning that. And yeah, I think when it comes together, it's really great, but obviously it's really hard work for it to come together, and it's not easy. I know that there are other colleagues in the room who would have a lot to say on how difficult it is, but also like some of the really successful stories in Lesotho, in particular around the alliance building, and the Gambia, and I'm sure there are other countries where it's really, really interesting to kind of like maybe share some information. I know that you already share quite a lot of information on alliances at the Global Maternal Mental Health Alliance, but obviously in terms of the economic work, it's really nice to kind of also share that as part of this network. Great. So I think we can just open it to maybe just the next seminar. So what we wanted to do at the next seminar, so this was like the more kind of like technical stuff that I wanted to cover, just so that people know what's kind of like being done, what we could do, but not necessarily kind of like to take the space, if you like, but more kind of like thinking about where to go next with this. Like obviously, this is all happening a little bit opportunistically, and as I said, like quite often unfunded and totally reliant on goodwill of people. This is not a formal job for any of us, I don't think. Well, maybe for some, but I don't think there are many people who have that job on. So we are all doing it kind of like a little bit in our own time and our own efforts, but we are quite passionate about it. And so the more we can kind of support each other, and I know that there's already quite a lot of support in the perinatal mental health space generally, but maybe if we can create that kind of like space for economics in particular, if there's a need, obviously only if there's a need. If we think there's no need, then there isn't. But just in terms of like how many people signed up and responded to the survey, I feel like there is maybe a need to talk about it more and network better and more. So at the next meeting, we have this kind of like amazing speakers lined up who can talk through their kind of like country experience of using economic evidence, really providing really nice insights. And doesn't always have to be just about perinatal mental health. It can be definitely about, like mental health generally, because sometimes that's how you find your way into maybe raising awareness of perinatal mental health. So I think it's really quite a kind of like broad way of looking at it. And I think that's it from my side. So I might just try to stop sharing. Shall we have a bit of a discussion on what you think, like any kind of reflections or
Yeah, we've got about 4 minutes. So if anyone wants to raise their hand and share any reflections or comments, feel free. I think I'll start off with saying thank you so much, Annette. It was a very interesting presentation, and I personally learned a lot. And being involved in little bits of it, seeing it all kind of come together was really eye-opening, essentially, to all of the labor that all of you do. But yeah, thank you. And it doesn't seem like there's any more comments. So maybe we could leave a little early.
Yeah, I think it's just maybe if you have questions, just email me and I try to bring them, because obviously this is all about asking questions. And I'm sorry that it took so much longer for me to just go through the content, but obviously, it's really helpful to have these kind of like additional questions. But maybe, if you want to email me, I can collate them. If you have any thoughts based on the presentation of where we could take things forward, and I bring them to the next meeting in June. And I hope that, a lot of you can kind of like really continue the discussion and kind of like stay on and, it would be amazing.